Next, I'm honored to introduce this morning's keynote speaker, Dr. Tunde Sotunde, President and CEO of Blue Cross Blue Shield of North Carolina. Blue Cross North Carolina is our largest insurer and provides coverage to more than 3.7 million members across all 100 counties. During his career, Dr. Sotunde has worked hand in hand with healthcare providers, consumers, employers, brokers, policymakers, and state and federal regulators to navigate complex challenges and lead health transformation across both public and private sectors. In his previous role, Dr. Sotunde served as the president overseeing Anthem's Medicaid and related state government businesses across 23 states and the District of Columbia. Dr. Sotunde was born in Nigeria, where he spent his early childhood before attending boarding school in England. In the early 1990s, Dr. Sotunde immigrated to the United States, where he completed his pediatric residency training. Please welcome Dr. Sotunde to our virtual stage.
Kelly, thanks for the introduction. Good morning, and thank you to all of you for inviting me here today to offer opening remarks at today's virtual healthcare conference. I really wish we could be doing this in person, but the fact that we're still able to move forward in this virtual environment, in my mind, is a testimony to the true grit of the business community here in the state of North Carolina, always focused on getting things done, irrespective of whatever circumstances or challenges we might find ourselves in. Again, I'm Dr. Tunde Sotunde, the President and CEO of Blue Cross Blue Shield of North Carolina. I'm a physician, a pediatrician by training, and I had the opportunity, the privilege, to take over the helm of the Blue Cross organization approximately 3.5 months ago, right in the midst of a pandemic, no less. Having said that, though, I am sure, no question, that for most of us, navigating successfully through this pandemic is the number one priority for us. However, this morning, I wanted to take the opportunity to share with all of you some of my perspectives on ways in which we can truly transform healthcare to be better, simpler, and more affordable for all North Carolinians. These perspectives are both from the vantage point of being an employer of 5,000 plus North Carolinians, and also from the vantage point of having the privilege to serve close to 4 million consumers across the state of North Carolina. These perspectives I often refer to as the 5 ingredients for better, simpler, more affordable healthcare. Not the entire recipe, but 5 key ingredients. Before I do that, though, I wanted to share with you the State of the Union with regards to healthcare across the United States, and specifically here in the state of North Carolina. Next slide, please. This was a study conducted by the Commonwealth Fund back in 2019 of per capita health spending across 12 industrialized nations, including the United States. As you can see on the far right, the per capita health spending in the United States is in excess of $10,000, which is twice the average of most of the other countries, 2 times higher than the United Kingdom, France, and even Canada, our neighbors next door. Public spending in the US was on par pretty much with the other countries, but out of pocket and private spending. And by the way, private spending includes employer-sponsored health coverage was materially higher, 2 to 3 times higher than the average. Next slide, please. So the next logical question, I'm sure for most of us, is what are we getting for all this money we're spending? Well, unfortunately, apparently it appears not a lot. In the same study, the Commonwealth Fund took a look at the performance of overall healthcare, or specifically health indicators. They looked at 45 domains for each of these countries and ranked them accordingly. Unfortunately, again, the United States was dead last in many of those domains. Lowering equity, access, prevention, care coordination, patient engagement, and overall health outcomes. Next slide, please. So where does North Carolina rank, or how are we faring in all of this? Well, unfortunately, the story doesn't get any better. In the same study, they ranked the state of health across all 50 states, plus the District of Columbia, and North Carolina ranked 34th out of 50 across several of those population health measures. Bottom percentile, third percentile on many measures. 46 out of 50 for health disparities, 42 out of 50 for access and affordability, 33 out of 50 for healthy living. Next slide, please. So it is some of this, what I've just shared, and my experiences as a physician, having practiced in the front lines, both here in the US and overseas, as an educator, having had the opportunity to train medical students and residents, as a healthcare executive, having built systems of care, and then last but not the least, as a patient myself, having had to navigate through the healthcare system at different points in my life, that has led me to the conclusion that there are 5 key ingredients, not the entire recipe, but 5 key ingredients that are essential towards driving to better, simpler, more affordable healthcare for all. These are 1, the health of our communities, 2, a whole person approach to care delivery, where we place the individual at the center of healthcare decision making. The third is collaboration, provider collaboration, and broader stakeholder collaboration. 4th is data analytics and insights, leveraging data analytics and insights so we can make better informed decisions. And then last but not the least, what I often describe as plain old common sense healthcare policies and regulations. Next slide, please. Let me now take a few minutes to walk through each of these 5 areas in a little bit more detail. I'll start off with community health, or the health of our communities. If there's one lesson, and we've learned several lessons, but if there's one lesson we've learned from this COVID-19 pandemic, it is simply this, that the health of each of us as individuals is interdependent on the health of one another. We cannot truly improve the health and well-being of individuals unless we address the health of the communities, those social, environmental, and economic factors that impact the health of our communities. Whether it is access to employment, fair housing opportunities, transportation, proper food and nutrition, basic primary healthcare services, addressing these social drivers are critically important. And by the way, these are the same social, environmental, and economic factors that tend to lead to inequities, which result in the health disparities that we all talk about. Which is why at Blue Cross Blue Shield of North Carolina, for many years now, decades, we have been focused on addressing the health of our communities. Last year alone, we spent close to $40 million through our community and diversity engagement efforts, and also our Blue Cross Foundation, a separate 501c3 organization, to support organizations and initiatives that were or are front and center of addressing these social needs and environmental factors in our communities. This year alone, we spent north of $15 million on specifically addressing issues, social issues, food insecurity, particularly that manifested even more so in the last several months following the onset of the COVID-19 pandemic. And our work is nowhere close to being done. Next slide, please. A whole person approach to care delivery. Absolutely addressing the physical, mental, emotional, and those social drivers of health, and doing it in an integrated, coordinated manner is critically essential to improving one's health. But we have to do it in such a manner that places the individual at the center of healthcare decision. When, where, and how do they want to access care? When, where, and how do they want to interact with us as a payer or their health insurance provider? Which is why exceptional experience, a consumer-centric or driving towards a consumer-centric approach to care delivery has been and will continue to be a priority of ours. To that end, we made significant investments on tools, capabilities, and resources, such as digital assets, to allow consumers and even providers to be able to interact with us in the manner that they so desire, when they so desire, and in real time, when possible. We have made significant investments in consumer decision support tools, such as our treatment cost estimator, our smart shopping tool, our RX prescription solutions tool that provides information to consumers on the cost of hundreds of services, procedures, cost of clinic visits, cost of drugs across several therapeutic categories, so that they can make fiscally prudent decisions, healthcare purchasing decisions. We've also made significant investments in upgrading our customer service capabilities to allow for more self-service optionality, and also for those that desire to call us or access us through online chat and other mechanisms, that we are able to drive to a one-call resolution. Next slide, please. Provider collaboration. I've often said this. Providers and payers share a symbiotic relationship. One cannot live without the other. It's as simple as that. Almost every provider I've spoken with in the last 3 to 5 years, and I happen to be a provider myself, so I also speak for myself, has always said, without question, Tunde, absolutely we share the same objectives. We want to ensure access for all. We want to improve the quality of care for our patients. We also want to drive down the overall cost of care and make care more affordable for our patients. So then what's the problem? The problem is we have a disconnect in our system today. We have a system where we pay for volume as opposed to paying for value and outcomes. And I will contend that you have a system that pays for volume, you're more likely to get more volume. The math is very simple. However, if you have a system that pays for value and outcomes, you're more likely to get more value and better outcomes, which is why at Blue Cross, 2 to 3 years ago, we embarked on the most comprehensive shift in the industry to shift from fee-for-service, paying for volume, to paying for value and outcomes, otherwise known as our Blue Premier program. Today, we have over half of our members that can be attributed to a primary care provider in some form of a value-based care arrangement. We just released year one results a few weeks ago, and it was extremely compelling. $153 million in savings in year one. But not only that, we're able to drive better quality and outcomes for our members. 3,000 more members got additional colorectal screenings. 13,000 hypertensive patients were reported to have their blood pressure under control. And Medicare star ratings, quality ratings, these are the ratings released by CMS every year, went up on an average of 3 to 4, actually was closer to 4.5 stars for the providers, primary care providers that were in the program during this period. I'd like to take this opportunity to thank some of our healthcare partners here today that were in the program in year one and were instrumental. It was the actions they took that drove these results. They include Code Health, UNC, Duke, WakeMed, Wake Forest Baptist, and the hundreds of primary care providers in accountable care arrangements that were really tip of the spear in delivering these compelling results. By 2023, our goal is to have 100%, right now we have 52%, 100% of our members that can be attributed to a primary care provider in one of these value-based care arrangements. And we're well on our way on that journey. Next slide, please. It's not just about provider collaboration, but also what I often describe as stakeholder collaboration. Especially when you find yourselves in a crisis like we find ourselves in today. It's literally taking a coalition of the willing to address the issues that all of us here have been grappling with around health equity. That all of us here have been grappling with around lack of PPE, personal protective equipment, manufacturing capabilities here in our state. Viral testing, contact tracing infrastructure, and so on. And very soon, everything going according to plan. Once we have a COVID-19 vaccine or COVID vaccine that's available in commercially available quantities, we're going to have to pivot to a mass vaccination campaign and all the logistics that surround that. And that, ladies and gentlemen, is going to involve a coalition of the willing to make things happen, particularly to ensure that those individuals in our communities, those of our communities that have been disproportionately impacted by this pandemic, gets the much needed vaccine. Next slide, please. Data analytics and insights. So here's the deal. In healthcare, I would contend we have a ton of data. Data is not our problem. The volume of data is not our problem, in my mind. The issue, though, is that it's fragmented, it's in different systems across our healthcare ecosystem that don't speak to each other. And then, of course, the quality of the data then becomes suspect. I personally find it mind-boggling that in this day and age, in the 21st century, none of us here have access to our longitudinal healthcare information in a meaningful, usable, readily accessible format at the touch of our fingertips, few clicks of a button. All of us here, though, have access to our financial information in the manner I just described, but not our healthcare information, which I will contend is probably the one most longitudinal information that we want to have at our fingertips, because it could mean a matter of life and death. I can tell you that from personal experience as a practicing physician. I bet you that if we had data all collated in a meaningful and usable format across all our ecosystems, we probably would have been able to predict when, where, and how COVID was going to hit our shores, how it was going to spread, what populations were going to be susceptible, and so on. The data was there, but it was disparate, to say the least. This is why at Blue Cross, we made significant investments in leveraging data analytics and insights. We are in the process of pulling all the data across our ecosystem so that we can have it in one place in a meaningful and usable format where we can now start to apply artificial intelligence, predictive modeling, and machine learning to drive better insights on healthcare patterns, provide better decision support tools for and data for our members and providers, and be able to do things internally faster, better, and cheaper. Next slide, please. Last but not the least, common sense healthcare policies and regulations. Let me just put it this way. All we need is common sense policies and regulations that drive access to care or improve access to care. I'll give you an example, the Affordable Care Act. Doesn't matter what side of the fence you side on, or you sit on rather, or which side you're on with respect to the ACA. The fact of the matter is here in North Carolina, it's provided for healthcare coverage, access for over 500,000 North Carolinians who otherwise may not have had healthcare today. Another example is telehealth. For 20 years, Blue Cross of North Carolina has covered telehealth services, but there have been policies or regulations around payments, around licensure requirements, this, that, and the other. And adoption was minimal, if not next to none. Well, guess what? Fast forward to COVID-19, when telehealth at the time was probably the only means of accessing non-emergent care. And what did we see? 1,000-fold, 2,000-fold increase in the use of telehealth. We can't go back. That I'm convinced we can't go back. And then policies, for example, I mentioned the issue around data, interoperability standards that allow systems to speak to each other in healthcare, so we can pull data together and unleash the power of data. And then last but not the least, payment reforms. We need payment reforms like we described or have been talking about around shifting from fee for service to value and outcomes, payment reforms around drug pricing, and so on. Next slide, please. So in closing, I have to take this opportunity as I end my opening remarks to remind all of us about the 3 W's. Wear your mask, wait 6 feet, and wash your hands. And again, thank you for the opportunity to be here today and to offer opening remarks. It's indeed an honor and privilege to have this opportunity. And I look forward to embarking on this journey with all of you together as we transform the health of North Carolinians to be better, simpler, and more affordable for all. Thank you again.
Thank you so much, Tunde. This was terrific. You have been preaching to the choir, I'm sure, to many people out there with common sense policy reforms and telehealth. I'm probably one of many who have know people who use telehealth during the crisis and would love to continue using it. I have a bajillion questions for you, but I will try to keep between the lane. Given that we still don't know where the pandemic is going, how long it's going to take to develop a vaccine, and we have a panel on that next, how long it will take to distribute, et cetera. Businesses still have to plan for the future, and they have employees. Some of them many of them are still remote. There are different issues with mental health and that kind of thing that have really percolated to the surface. What do you think is on the horizon for 2021, not just for rates, but that would be of interest, I'm sure, but also just healthcare packages and how employers in particular should be caring for their employees, and where do you think more broadly healthcare is headed in the next year or so? And that's just a small question.
There's a lot of questions. I think there were about 10 questions in there, Kelly. But let me take a stab at it. So here is, I wish I had a crystal ball, obviously. I'm sure like many of us to be able to look into the future. But here's what I would say. You know, the irony of this COVID-19 unfortunate pandemic we're dealing with is that it's taught us a lot of lessons. And I believe that if we follow through and stay true to the lessons that we're learning, I truly believe that we will come out healthier and stronger on the other side of these challenges, that we will accelerate even more so down the path, the quest of equitable access for all, improving the quality of care for all and outcomes, of course, and then making healthcare more affordable, to your point. Why do I say that? Let me share with you a couple of data points or facts. One, the health of our communities. This pandemic has shone a light on fractures we have in our system, in our society. It's shone a light on the magnitude of health disparities. Many of us in healthcare have known about health disparities. We've been talking about health disparities for decades. When I was in training, we were talking about health disparities. I don't know that we understood the magnitude of the disparities, racial and ethnic, socioeconomic, what have you, until this COVID pandemic manifested. It's shone a light on hundreds of thousands of North Carolinians are living very close to the federal poverty line. All of us saw the food lines, long food lines that manifested within weeks, not even 6 months, a year, weeks of the pandemic. And then, of course, the issues around lack of PPE, testing, viral contact tracing, and so on, which gives you, all of us, you know, a wake-up call with respect to the state of our public health system. So if we stay true to all that we are all grappling around, because all of us here are grappling around these issues and deploying solutions left and right, if we maintain those actions we've taken, we'll be better off. I'll give you another example, telehealth. You mentioned telehealth.
That's like a burning question in the audience. It's a burning question with hospital, I mean, everywhere, yeah.
20 years we've been covering telehealth, but there have been restrictions, constraints, this, that, and the other, right? I call it excuses. All across the entire ecosystem. Fast forward COVID-19, voila, here we are. So what I will say, we're not going back. I think I kind of mentioned this. Now, the question is, what is it going to look like going forward? That's something we're actually working on right now at Blue Cross. And we're thinking about it more holistically. I'll describe it this way: virtual care. So telehealth is more than just, face-to-face visits, right, for care. Think about how we could leverage it for counseling. Think about how we could leverage it for environmental assessments. Think about how we could leverage it for remote home monitoring. Think about how we could leverage it to even do simple diagnostics, right? Where you have, basic diagnostic tools that are available to the consumer, right? A stethoscope, an otoscope, I can look in your ear, just plug it into a little console, and then I can see what's actually going on. I can listen to your heart, leveraging audiovisual technology, and it helps with my ability to make a more accurate diagnosis and so on. That's where we're going, in my mind. That's where we should go, but that's where we are going from a Blue Cross perspective. And then accelerate to value. I mentioned this thing about fee for service, paying for volume, as opposed to value and outcomes. So guess what? When you pay for volume and the volume starts to shrink up, what happens? You now put the very fabric of our healthcare delivery system in jeopardy. So what we're learning is going to, in my mind, if we stay true, actually drive towards a more viable and sustainable healthcare delivery system at the end of the day.
So another kind of topic that you clearly are passionate about is disparities in healthcare. Mm-hmm. And that can be everything. When we look at social determinants of health, we look at food insecurity. Mm-hmm. One question that a panelist had, and then maybe you could roll this into the larger question, is when we're looking at the United States vis-a-vis other countries, lots of times they pay for social determinants kind of things. And so one question was, are some of those costs baked into other countries' per capita healthcare spending, like social determinant kind of issues and help with transportation and food and all that? But tell us a little bit more about what it would mean to correct some of these inequalities and these disparities, and why you feel like it's so critically important.
Yeah, well, like I said, we've known about this. You can talk to probably any healthcare provider, and they will, tell you about health disparities and their experiences. There's a ton of published data around all of this. Again, I don't know that we realize the magnitude. So let me speak for myself. I don't know that I personally realized the magnitude until this crisis. But here is how I think about disparities. I think about it in a more holistic, from a more holistic standpoint. So there's socioeconomic, there's racial and ethnic, there's gender, there's generational, right? Elderly to baby boomers like me, and then millennials, generation X, Y, whatever, right? There is geographical disparities. So guess what? There's a study that's, I think maybe about 3-4 years old, that was done here in North Carolina. Adult male in Wake County, life expectancy, 79 years. Adult female, Wake County, life expectancy, 83 years. Sorry, guys. That's just the way it is, right? FYI, if you didn't know. Guess what? Swain County, they corrected for all other factors. So similar profile, adult male, life expectancy 70 years. Female, life expectancy 78 years. So just look at that. For males, almost a 10-year delta. Females, almost a 5-year delta, depending on just where you live. So we have to think about these inequities or disparities in the true sense of the word and look at it really holistically. And that's where I think we've talked about it, we've talked the talk, we really have to walk the walk. And really, it has to be a core component. And you're right, in many of those countries, I actually spent time in the United Kingdom, and I was covered, actually I still am, by the NHS, believe it or not, the National Health Services. So yes, I would say that healthcare system is more geared towards primary, public, community health as opposed to tertiary care. Our system, in my mind, is more geared towards tertiary care. If you have a heart attack or you need a hip replacement, this is the place you want to be. You want to be in the United States. There's no question about it. So acute care, no question. But we have to think about care across the continuum.
I knew this would happen. There's so many questions I could ask you, and we've already come up on break. I just cannot thank you enough for spending the time today and laying out your vision. And I know it's just a part of your vision. I'm sure you have, as we talked earlier, a book of a vision. But welcome to North Carolina. We promise it'll settle down and you will get to go to all 100 counties at some point. But thank you so much again for your time. We really, really appreciate it.
Kelly, thanks, and thank you to all for having me.